Good afternoon, respected chairperson on the dais and all the dignitaries, my colleagues, Dr. Nageswar sir and the juniors of the dais. It's a great opportunity. Actually, this presentation on behalf of my colleagues, Dr. Saha, he is not here because of his dad's illness. So I would like to take next 10-12 minutes. We have last couple of hours, we have seen and learned a lot of things regarding the fetal echocardiography. That is one of the emerging fields and which is very important in view of increasing number of congenital cardiac illness and their procedures in the early life to make their future very smooth. So it's an institutional experience from where I'm working now at a tertiary care center over a span of 5 years. And this fetal echo done in the hospital and its satellite center in different parts of this part of the country. And we have picked up the significant major cardiac problem around 112, and it's around 2 to 2.4%. During this period, which we have across 8 babies who are diagnosed during the fetal life mid-trimester or little late with different forms of cardiac abnormalities, and the baby was delivered, few of them in the hospital in a planned way and majority delivered outside, but they came to us for the next procedure or intervention, which are some of them are curative for the rest of the life and few are just palliative to send to the other better center where the cardiac surgical intervention can be. This is the image. You can appreciate the 4-chamber view. The left ventricle is significantly dilated and significant mitral regurgitation is there with LV dysfunction. And the right side, you see the aortic valve leaflets not moving properly. So it was a diagnosis of actually aortic stenosis with mild to moderate to severe LV dysfunction. And on the echo Doppler, you can appreciate this kind of dysfunction of the LV. The aortic antegrade gradient was almost 170 centimeter per second. And on the right side, see the aortic annulus and the dilated ascending aorta. And this baby came to us and we planned for routine procedure as a pediatric cardiologist do in every center. There is a aortic valvoplasty and it was done and baby is on follow-up. These clips are not playing actually. I'm really sorry for that. The second case, it was diagnosed around 26 of pregnancy and we got the right-sided chambers are significantly dilated and descending thoracic aorta was also dilated. That was the clue, and it was a case of, as in the quiz portion, there is one case evolving coarctation of aorta. The lady was on follow-up, baby was delivered outside, and we asked to come for follow-up after the delivery, and it was picked up as coarctation of aorta, which was again treated by balloon coarctoplasty with a tie-shack balloon. The third case, it came to us at little late gestation, and it was simple severe pulmonary stenosis. I lost the fetal imaging because of the technical fault. The machine crashed in that time. I forgot to take the images. So it was a critical pulmonary stenosis, but we did the procedure in our hospital and single procedure, as you know, if it is done proper size balloon and the child is grown up almost more than 1 year and doing very well. And it was inflated with the 6 millimeter tie-shack balloon. This is the case. It came to us very late pregnancy, it was just reconfirmation of the diagnosis tetralogy of Fallot. And initially it was diagnosed as a case of plain VSD, but after doing the fetal echo proper way, you can appreciate there is a perimembranous VSD and malalignment of the aorta. And during the right ventricular outflow, the later part of the video, you see there is a turbulence across the right ventricular outflow tract, suggestive of pulmonary stenosis. And the gradient on the other side, see, it is more than 160 or near 170 centimeter. So we made the diagnosis tough with pulmonary stenosis. Baby delivered in the city and came to us after the baby was born. And here the procedure, which ideal, I don't know, but after 1 month of age, the baby was desaturating a little bit. And there was a question whether baby need BT shunt or not. My center having very poor surgical backup, and I offered them to go to other center. And after doing the proper neonatal echo, it showed there is the pulmonary stenosis two component. The valvular component was more predominant than infundibular. So I took a risk of explaining to the family. I went for balloon pulmonary valvuloplasty in a case of tetralogy fellow with significant predominant pulmonary valvular stenosis, and the child had successful procedure, the saturation improved. So we got at least more than 8 to 10 months of age for the final surgical correction, and the child is under follow-up and doing very well. This is a case which was diagnosed in the satellite center. Apparently the 4-chamber view was normal. 4-chamber view was normal, but when we are trying to take the outflow view, you can appreciate the anterior vessels which is coming, giving the neck vessels. So from the basic knowledge, if the anterior vessel coming from the right ventricle and giving the neck vessel branching, that means it's aorta. Whereas the posterior vessel, which is smooth rather, suggestive of pulmonary artery. So it was actually diagnosis of TGA with intact ventricular septum, and the baby was delivered outside, came, and we did the balloon atrial septostomy. There's a routine procedure. This is the echo procedure was done under fluoroscopy, and we have simultaneously documented transthoracic echo. And the last, we have diagnosed almost 3 cases with diagnosis of pulmonary atresia with intact ventricular septum. The right atrium is dilated. There is significant tear, which is very hypertensive, and IVS bulging towards the LV. And you can appreciate the right-sided ventricles very much smallish as compared to the left ventricle. The complete diagnosis was the pulmonary atresia with intact ventricular septum, and the pulmonary valve was there was a valve but no antegrade flow. I don't have the color image Doppler, but the diagnosis is pulmonary atresia intact ventricular septum. We have done 3 cases with PA-IVS, and 3 cases we have done the ductal stenting, and the baby is doing well. 2 have been sent for the next stage of surgery. So in this time span, we have done 8 babies with different cardiac problems, starting from the left side of the heart obstruction, right-sided heart obstruction, some mixing lesion, and complex heart disease like PA-IVS. And we could do the procedure successfully. So that is the number. So at the end, the congenital heart disease is a wide spectrum, and it can be diagnosed if we adopt in our practice, not in the apex center, who are also doing the periphery. So if we do routinely or promote fetal echocardiography, we can pick up, because 1/3 of the congenital heart disease is very severe, and those need early intervention. Otherwise, they can't celebrate their first birthday. That is the importance. So this is very important. So fetal echo, I think, is not, it is a topic for discussion, what is the importance. But as there is some part beyond the cities, there is a lot of inhibition sending for fetal echo, only anomalies can, even so many places we see, we visit, even they are not sent for the complete anomaly scan. So importance is how it can be implemented beyond the cities. And early diagnosis by fetal echocardiography can helpful for the family, and it can avoid some unexpected result and morbidity, mortality. And if it can be done at the right center and the right time, the long-term future prognosis can be very good. Thank you so much.